हेलो हेलो, हाँ लाइव कर दी, लाइव है, शुरू कर रहे हैं। ओके थैंक यू। So good evening everyone. If I'm visible and audible, just let me know guys. We'll start with the session. Yes. So good evening guys. Alright, so let me start with the session. If there are any questions or doubts, we'll handle them in between. So I have the questions, I'll be just seeing the images right in front, I'll have the messages right in front of me. So let's start guys. Okay, so this is our session of the FMGE image based questions, and we'll be discussing the anesthesia part, the image based questions. A lot of questions from the anesthesia come as image based questions also. Okay, so going forward, we'll be covering up the image based questions asked from the different parts of anesthesia. For example, airway, questions which are there important for intubation. We are going to discuss various parts of the monitors. We are going to discuss about the CPR. We'll be discussing about the spinal and epidural. Okay, so basically these are the places where image based questions are asked, and these are also the major topics of anesthesia where questions get asked in the exam. So this is what we'll be covering up: the airway, the monitors, CPR, spinal, epidural. So these are the basic topics to be covered from anesthesia point of view. The session is going to be based on the previous MCQs which have been there, and apart from that, the other image based questions based on the similar MCQs or the similar topics. So what we are covering is basically the previous year's questions which are image based questions, and along with that we are also covering up the previous year's topics. So in turn, it's not just the previous year's questions that are getting covered, we are also going to cover the previous year's topics. So let's start guys. The questions will be in terms of MCQs which have already been asked in the exam. So we are going to discuss MCQs, along with that additional points based on the same topics which are there. So this becomes your previous year question and previous year topics both mixed together. So starting guys, this is the first one. Which of the following grading systems is being depicted in the image? Okay, so if you can just answer the question to me directly. So this is the, okay, so I can see messages from people. Yeah, Dr. Veer is there. Good evening guys, I can see all your messages now. Dr. Damchi Lena says Malampatti. Absolutely correct. This is Malampatti grading. Alright. And this is not a 𝐒𝐿. I'm going to cover up very fast. If there are any doubts, please ask me in between, because I just want the revision to get over as early as possible. This is not 𝐒𝐿, not ASA grading and not AHA. Before going forward, remember 𝐒𝐿 grading is basically sort of ENT or anesthesia. Basically, it is a laryngoscopic grading which is called as the 𝐒𝐿 grading. ASA, this is American Society of Anesthesiologists grading, and remember, a question based on this was asked recently in the INI-CET ASA grading, where they've asked you ASA 1, ASA 2, ASA 3, ASA 4, ASA 5 and ASA 6. Okay, so ASA grading guys is again an important recent topic which has been there. So ASA grading is of 6 types: ASA 1, ASA 2, ASA 3, ASA 4, ASA 5 and ASA 6. Remember, ASA 1 is any normal patient. We are discussing about the medical problems of the patient, or the medical status, or basically the physical status of the patient, or the medical illness or the medical problems. ASA 1 is a normal patient. ASA 2 is anyone with a mild systemic abnormality or slight physiological deviations like pregnancy and all. Okay, Anything which is becoming moderate to severe, but books have mentioned it as severe. Remember this. Exam question what asked was regarding severe. A severe systemic illness or a problem becomes ESA grade 3, which is uncontrolled. ESA grade 4, so severe systemic problem that it becomes a threat to life. Alright, patients like angina, exacerbation of COPD, CRF. ESA 5, moribund patient not expected to survive, means someone is to be taken up for surgery, with or without surgery the patient will not survive. So this is moribund patient not expected to survive. ESA 6 is a brain dead patient. Okay, this is for organ transplant. So this is your ESA grading. All right, American Society of Anesthesiologists grading. This is done before as a part of the pre-anesthetic checkup before we take up the patient for surgery or giving anesthesia, right? And what is depicted in the image is the Malampatti. So going forward, Malampatti, guys, tells you about the posterior pharyngeal structures. So you ask the patient to open the mouth, you ask the patient to extend the tongue, and then what we are doing is we ask the patient not to phonate. Okay, so open the mouth, extend the tongue, and do not phonate. What are we going to do, guys? We are going to look at the posterior pharyngeal structures. The posterior pharyngeal structures, if all the structures are visible, I'm going fast over here. All the post structures means if you can see the complete uvula, you can see the tonsillar pillars, if you can see the fauces, you can see the soft palate and the hard palate, it is Malampatti 1. If this uvula gets cut half, you just see, the tip is not visible now. The tip of the uvula is seen in Malampatti 2. The pillars are half, fauces are half, and the soft palate, hard palate can be seen, that is Malampatti 2. If you cut it from here like this, that becomes Malampatti 3, which means only the base of the uvula is seen, right? Tonsillar pillars and fauces are not seen, but soft palate, hard palate are seen. Malampatti 4, nothing but the hard palate is seen. So, right? So remember, just by looking at the uvula, you can understand it is Malampatti 1, 2, 3 and 4. If it is visible, Malampatti 1, not visible, Malampatti 4, and if just the tip is not visible, Malampatti 2, and only the base is seen, Malampatti 3. So just by that one structure, you can identify Malampatti as an image-based question. Importance, this is what is called as the 𝐒𝐿 grading. When you do laryngoscopy of a patient, so this is what is called as 𝐒𝐿 grading, which was given before as an option. It is also called as a laryngoscopic grading, that in Malampatti 1 and 2, you can see the vocal cords. In Malampatti 3 and 4, you are not able to see the vocal cords. Thereby, Malampatti 1 and 2 relatively become a easy intubation, easy mask ventilation or easy airway. On the other hand, Malampatti 3 and 4 would become a difficult mask ventilation, difficult airway or difficult intubation, or difficult laryngoscopy. That's the whole point about Malampatti. So this is what we have covered here. Malampatti, how to do Malampatti classification, and we've also done the 𝐒𝐿 grading. So this 𝐒𝐿 grading, which has been mentioned over here, this image is what is seen here below. Okay, so this is your 𝐒𝐿 grading, the one which you see below. Thumbs up everyone. We'll go to the next one. Yes guys. Okay, the patient of COVID, this was basically COVID time question, so it's the same thing getting repeated the same way, but can be asked without COVID as well. Alright, so the patient was required oxygen therapy. Which of the following cylinders should be used to provide oxygen to this patient? Right, they've given 4 cylinders. Now this was an image based question. Options given were A, B, C and D. Here the correct answer would become B. B is the oxygen cylinder that you see, because this is based on the color of the cylinders, right? Another important question that comes in the exam. So let's revise the colors of the cylinder and the pin index numbers. Both can be asked in the exam, right? So these are the pin index which you see. Remember, pin index system is what prevents the wrong attachment of cylinders, right? It's called the pin index safety system. This prevents the wrong attachment of the cylinders. Okay, this is going to prevent the wrong attachment of cylinders. So the pins are the ones which lie on the anesthesia machine, and the corresponding holes or the grooves, they lie on the cylinders, right? The corresponding pin receivers, you can say, or the grooves, they lie on the cylinders, right? So when you're talking about a cylinder, they are going to ask you an important question about regarding the colors as well as pin index. So we have 5 important gases for which you need to know, right? The first one is air, the next is oxygen, another one is nitrous oxide. You also need to know NOx and carbon dioxide. So these are 5 gases for which you should be knowing the colors as well as the pin index numbers. The color of air, this is basically gray body with black and white shoulder. Oxygen cylinder is basically black body with a white shoulder. Nitrous oxide is blue in color. NOx is basically blue with white or blue with blue and white shoulder. Carbon dioxide is grey in color, right? You can also be knowing helium. Normally it is asked along with oxygen, which is called as the heliox. That is brown in color with white. Okay, that is helium or heliox. Now, if you want to know the pin index numbers, remember the first 3 gases are the ones 1, 2, and 3. You can remember them at 1, 5, 2, 5, and 3, 5. They are the pin index numbers of the first 3 gases. 1, 5 is for air, 2, 5 is for oxygen, 3, 5 is nitrous. 1, 2, 3. NOx, the biggest name, gets the number 7. All right. And carbon dioxide, basically, there are 2 numbers that you can have for carbon dioxide, which is 1, 6 and 2, 6. That depends on the percentage of carbon dioxide present in the cylinder. Helium has a number of 2, 4 or 4, 6. Okay. So therefore, if you get a number 6 in the exam, remember you can always go for carbon dioxide, because another one is cyclopropane, which we don't ask. So if you get the number 6, normally what they're going to ask you is carbon dioxide as a pin index. If you get the number 4, think of helium, right? Because no other gases has the number 4, right? And 5, when it comes in the end, remember 1, 2, and 3, air, oxygen, and nitrous, the important gases which are there. So this is our pin index numbers, and these are the colors of the cylinder. Now, you are also supposed to be knowing the colors of the pipelines. So these are the pipelines. Pipelines are the part of intermediate pressure system, right? So the first one which you can see is oxygen. Remember, oxygen is always white in color, right? So wherever there is oxygen, there is always white in color. So pipelines also, when I'm discussing these pipelines, and we have to discuss the colors of the pipeline, right? So oxygen is always white in color. Nitrous oxide, remember, is always blue in color. You get air, this is black in color, and you get vacuum, which is used for suctioning, that is yellow in color, right? So this is regarding the pipelines. Also, if someone asks you the flow meter knob or the knobs, so remember, wherever you get oxygen, it is white and nitrous is going to be blue. So if someone says, what is the color of the oxygen knob, right? This question has been asked before. So oxygen knob is going to be white in color, and it has broad serrations. So this lies on the anesthesia machine, right? It's a flow meter knob or the flow control valve, which we call. And the nitrous knob, remember, what will be the color? Blue, right? And compared to oxygen, it has thin serrations or thin grooves. So this completes the color coding. Now, last one that we will see before we go forward is on the anesthesia machine. There are various vaporizers. Even the colors of these vaporizers become important. So remember, always halothane is red in color, fiery red. That's why it has got lots of complications. Simple colors, soothing colors. What are the soothing colors? Purple and yellow, right? So purple is isoflurane, right? So isoflurane, which you see over here, is purple in color, right? Then you see another soothing color, yellow, right? Warm color, yellow. So therefore that is sevoflurane, and these two are maximum used everywhere. Most of the places you find isoflurane, sevoflurane as the drug of choice, most of the places, right? And sevoflurane is what is yellow in color. You get blue in color, and this is desflurane. But you find that the construction of the vaporizer is slightly different. This was last year's January FMGE question asked in the exam as an image based question, where they had given you this image and asked you to identify. That is a desflurane vaporizer. It is blue in color, and in construction it seems to be slightly different from others. The reason is desflurane boils at 23 degree or room temperature. It has got highest saturated vapor pressure, because of which it needs a special vaporizer, and this special vaporizer is what you see, which was asked in the exam. Okay, this is what is called as a special vaporizer, right? And this is electrically heated. It has got an electrical supply. That is why desflurane is different from others. It is called as a Tech 6. They won't ask you Tech 6 in the exam, but that's the name of it. Okay. Yes, guys, any question? All of you okay? Right. I've got all your answers. Correct. All of you have answered well. I'm seeing all of you. Dr. Anonymous, Dr. Damchalin, Dr. Veer. Right. So we are done with all the colors. We have finished all of them. And as I said, I'm going to go a little fast because it is just a revision. I know you people know it. It is just to revise fast. Now, very important question. Every second year they are asking this. So I'll discuss this also very fast, and you people can give the answer if you want to. Right. So I've got all the answers from you for the questions that I asked before. Now this one, which of the following option is correct regarding the layers pierced during adjoining procedure being shown in the image? वो घुमा के एक question पूछते हैं वो. The same question, you know, they keep on changing the formation and they ask you. So skin, subacute, ligamentum flavum, supraspinous or interspinous, they've interchanged all of them. You need to remember what is the correct order of the layers getting pierced during spinal, epidural or lumbar puncture. So this question can be asked in 3 ways. The layers punctured during spinal, the layers punctured during epidural, or the layers punctured during lumbar puncture. Remember, lumbar puncture and the spinal is the same thing, the same layers get punctured. Epidural is something, epidural. Before the dura, answer is given in the name only. Epidural means, extradural means outside the dura. So epidural is outside the dura, spine is going to be after the dura, but not exactly dura, it is arachnoid. So what is the correct answer here? This image being shown is of a catheter, and you insert a catheter when you're putting an epidural, not when you're giving a spinal. Routinely this is what is done. So what is going to happen here? Which answer is correct? You are going to get skin, subacute, this is correct. Okay, so skin and subacute are there everywhere. Then here straight away ligamentum flavum is given as a third thing. Here they are given supraspinous, interspinous, which is correct, and the same thing is repeated over here, right? So the first option is absolutely out. In the second option, you find the last layer is dura, right? Here the last option is given is ligamentum flavum, and here the last option is given is intervertebral disc. Again, this is out. Intervertebral disc is out. Your confusion would be lying between our options B and C. Remember, epidural space is outside the dura, so this is out. Therefore, the correct answer becomes ligamentum flavum. As soon as you puncture the ligamentum flavum, you are reaching the epidural space. So the correct answer is skin, subcutaneous fascia, supraspinous, interspinous ligament, and then comes ligamentum flavum. So just to revise through this question and go through it fast, remember the first layer that you get to see is the skin. The first thing that you get to see is the skin. Then what you get to see is the subcutaneous tissue. Asha, before I go there, remember this thing which you see over here. Okay, this thing which you see over here is the spinal cord. Remember, spinal cord starts at medulla oblongata and gets over at the lower border of L1, upper border of L2 in adult, and it gets over at the lower border of L3 in a child. Important point, right? So that is the reason when you are giving spinal anesthesia, because you're going to puncture and go inside, you don't want to puncture or create damage to the spinal cord, and that is why spinal anesthesia is always given below L1, L2, so that you don't damage the spinal cord of the patient. Correct? Now the layers getting pierced, the first thing you get is the skin, then what you get is the subcutaneous tissue or the subcutaneous fascia. After that, there is one layer covering up the spinous process, which is called as the supraspinous ligament. Then you get a layer in between the spinous process, which is called as the interspinous ligament. Then you get a ligament just after the interspinous ligament, and this is what is called as ligamentum flavum. So this is what is called as ligamentum flavum or ligamentum flava, either of that, right? Now, once you've crossed ligamentum flavum, guys, immediately you cross ligamentum flavum, you straight away reach this area which is called as the epidural. Immediately, epidural. It's a small space, 5 millimeter in thickness, 5 centimeter from the skin, right? And you find this space by using a technique called as loss of resistance. Not going to go into too much details. It's a negative pressure space in continuation with the thoracic cavity. So therefore, you find this space by loss of resistance technique. Loss of resistance to air or saline. There are other techniques also, but these are the important ones. Done. That is epidural. Once you cross epidural, remember after ligamentum flavum we came to epidural, which is extradural, which means outside the dura. So the next layer definitely is going to be the dura. So this layer which you get is what is called as the dura. Therefore, in the question asked before, The correct answer was as soon as you cross ligamentum flavum is when you get into the epidural space, right? After the epidural comes the dura mater. Remember, dura extends in an adult up to S2, in a child it goes up to S4. And along with the dura, so it is the first layer of the meninges. Along with that, you get the second layer almost attached to it, which is called as the arachnoid. So dura and arachnoid are almost stuck onto each other, right, with a small subdural space in between. And what comes after the arachnoid is what is called as the subarachnoid space, right? And the subarachnoid space is what contains the CSF. So therefore, this is where you do the lumbar puncture, and this is where you give the spinal anesthesia, where there is CSF. So now, what is the last layer to be punctured before giving spinal or doing lumbar puncture? The answer becomes arachnoid. And what is the last layer to be getting punctured before giving epidural? The answer becomes ligamentum flavum. Thumbs up everyone. Is that okay, guys? These are the layers which are there. In between the messages disappear. Then all of a sudden I get all your messages together. Okay, if there are any questions, please ask me, guys. I can see myself, but I can't see your messages. That's the problem. Yes. Okay, I think all of you have understood. Clear. हाँ, अब आ रहे हैं यार messages. बीच में messages ही नहीं आ रहे थे यार, मेरे को समझ में नहीं आ रहा था. ठीक है, now I got the messages. Fast. Next, identify the needle. Again, image-based question. Guys, identify. जल्दी. Identify. Yes. Okay, so what is this? 𝐂𝐿. Dr. Veer says 𝐂𝐿. Correct. This is what is called as the epidural needle or the 𝐂𝐿 needle. Very nice. Okay. So this is what is called as the correct. Dr. Veer, I got your message. Right. I got your message. I'm just going to go. So I'm just writing it down so that you know this is also available. This will be available on the channel. Huh? So whatever I'm writing, we are going to save it as a PDF format and share it with you along with the images. This is what is called as the 𝐂𝐿 needle. Right. And if you will see, the tip of the 𝐂𝐿 needle is curved, and that is called as a Hubert tip. It has got a curved tip, and the tip is what is called as the Hubert tip. You will see that it has got 1 centimeter marking, so that you know how far you are from the skin. Is it for spinal? No. This is what is used for an epidural, and because it is used for epidural, remember it is a thick needle. So remember T for 𝐂𝐿 and T for thick. A thick needle is the 𝐂𝐿 needle, from where you can pass a catheter inside, right? From an epidural, what you do? You need to pass a catheter. Correct? So that's the 𝐂𝐿 needle which you see. Next needle. So this is again a needle. It has got no markings. So therefore now there's a needle which has no markings. But look at the tip. This tip is a what is called as the cutting needle. But this is a spinal needle. Okay, so this is a spinal needle which you see. There are two names for that. You can call it as a 𝐌𝐞𝐝, or Pitkin. These are the two types of spinal needles, right? And these are so when they puncture the dura, they leave a bigger dural rent. Imagine if this is puncturing, this is the dura, they puncture the dura. Can you see? The dural hole or the dural rent will be this much big in size. So therefore, this is called as a cutting needle. Okay, this is no, it is not Viris. Dr. Veer, na, ये एग्जाम में पूछा हुआ क्वेश्चन है, Viris नहीं है. This is a spinal needle. That's why I'm discussing this. Huh? Correct, Dr. Veer. Spinal needle. This is what is called as dura cutting. It cuts the dura. So this is called as a dura cutting spinal needle, and because of which it leaves a bigger dural rent. And if this much is the bigger dural rent, remember CSF loss is more. Hence, this type of dura cutting spinal needle, it has more incidences of CSF loss, leading to higher incidence of post-dural puncture headache. So this is what is called as a dura cutting needle, and that is why nowadays we don't use this needle so much. Okay, and what is preferred to be used is a dura separating needle. If you see, this is what is called as a pencil tip needle. If you will see, the tip is like a pencil, right? Here the tip is a cutting. This is called as cutting. This cuts the dura. And if you will see in the next image, this you will find the tip is pencil tip. All right. So this is a pencil tip spinal needle. So is this a dura cutting? No, this is not a dura cutting. this becomes dura splitting or dura separating. Dura splitting or dura separating. Okay. Now the point is, imagine if this is the dura now, how much big dural rent is there? You just need to puncture here and then the CSF will flow from here outside, right? So therefore, or if it is going in till here, so this is the place where it leaves a dural rent. Compared to the bevel which was this big, this would leave a dural rent only till this much, this size. So can you see? Initially the dura cutting was this big and this dura separating is this much. So therefore it leads to less chances, less CSF loss compared to the dura cutting, less incidences of post-dural puncture headache, right? Done. Next one. This is a case with the following image as given, shown, right? It is showing the mark 𝐸𝐶TO value as 40, right? So what does it indicate? The next one. Does it indicate expired O2? Is it a value of capnography? Is it a pressure of gases while breathing, or it is inspired CO2? Yes, anyone? What would be the answer? So simple question here, EtCO2. What is the full form of EtCO2? End tidal carbon dioxide. So is it expired oxygen? Out of question. Is it inspired carbon dioxide? Out of question. Is it pressure of gases? No, it's the value of capnography. So capnography is a very important monitor that gets asked in the exam, and this is a normal value itself. A normal value of capnography is 30 to 35, at the max 40, which is almost the same as PCO2. Correct, Dr. Veer, absolutely correct. Okay. Now, next question based on same thing. A capnograph was obtained from an intubated patient undergoing controlled ventilation. Which of the following is the likely finding seen? Is it esophageal intubation that you can see over here? Is it inspiration with cardiac oscillations? Is it bronchospasm or a spontaneous respiratory effort? So, in this question, if it goes into the esophagus, you will get no carbon dioxide. Here you can see carbon dioxide. Inspiration with cardiac oscillations is going to be seen over here, which you can't see because this is the expiration and this part is the inspiration, which you can't see. Bronchospasm will have a shark fin appearance like this, right? So what you can see over here is basically a spontaneous respiratory effort of the patient which has come back. Correct, Dr. V? Absolutely correct. Okay. So the correct answer here is spontaneous respiratory effort. Okay, absolutely correct. Now, so before I just go forward, guys, remember capnography has a lot of questions that keep on getting asked. So I'll just discuss that fast. Now, if you get a graph like this, this means a normal carbon dioxide graph coming out, which means IPPV or controlled ventilation is going on, right? It is controlled ventilation going on. This means correct intubation was done or correct ventilation of the patient is taking place. Now, if you get a graph suddenly which has fallen down, it means carbon dioxide is not coming out. So what are the reasons where carbon dioxide has suddenly, no, before I go there, wait. Before I go there, this was a patient with IPPV. Now, when someone is breathing spontaneously, like for example, I take a carbon dioxide monitor and put it in front of my nose, CO2 is coming out, na? So I am going to get a graph there also. So this is what is called as a spontaneous breathing. When someone is breathing spontaneously, the graph changes slightly. Same thing, but the graph goes up means expiration, graph going down means inspiration. So if IPPV is going on and suddenly you get a graph like this, means someone has tried to breathe spontaneously. This means IPPV was going on, means controlled ventilation, correct intubation, everything is fine. But suddenly during IPPV, the patient tried to breathe spontaneously, because of which you get this graph, and this is also called as a curare cleft. Not important for exam, so let's leave it. ठीक है, छोड़ देते हैं. Exam में पूछा जाता है, but I don't expect that in FMGE. Normally they don't ask. Curare cleft. ठीक है. Next point. You get a graph suddenly which goes like this. It means carbon dioxide is not coming out, which means this must have gone into the esophagus. Esophageal intubation means wrong intubation. That's why capnography is said to be the best method to detect intubation is capnography, because if it goes into the esophagus, you will get no carbon dioxide. But a similar graph can also be seen if there is a cardiac arrest and if there is no metabolism taking place. A similar graph will be seen if there is a disconnection from the circuit. A similar graph is seen if the patient gets extubated. By chance the tube comes out, right? And a graph like this, not exactly, but a graph slowly progressing down and down and down and down is a common question. Remember, embolism. embolism, and especially during laparoscopy. Why? Because when you are using laparoscopy, remember we insufflate the stomach with carbon dioxide. So when the carbon dioxide is insufflated in the stomach, it will be absorbed in the bloodstream. So you expect the graph to go up in laparoscopy. In fact, this is the graph which you should get with laparoscopy. Because carbon dioxide has been given to the patient inside the stomach, some amount will get absorbed in the bloodstream. So this is the graph which you see with laparoscopy. But in laparoscopy, if suddenly the graph falls down, so therefore the hallmark for embolism is decreased EtCO2 and decreased SpO2, and this question has been asked in INI-CET as well as in NEET PG. It's a proper clinical question that carbon dioxide is going, a patient has been operated, being operated under laparoscopy. Suddenly there's a fall in EtCO2, fall in SpO2, and the peak pressures remain normal. What are the options? So the correct answer there is embolism. This question has been asked twice or thrice in the last 2-3 years. Okay. So remember this point, in laparoscopy you expect the graph to go up, but if the graph is going down, especially in laparoscopy, and saturation is also going down, it means it is embolism. Other reasons for the graph to increase will be malignant hyperthermia or anything that increases metabolism. For example, if there is fever, thyrotoxicosis, or if there is sepsis. A graph in getting increased and not touching the baseline, it means someone is rebreathing this own carbon dioxide, and this is called as step ladder pattern. Rebreathing own carbon dioxide. This is seen with the soda lime circuit when it becomes full. Okay, so this is one graph, and let's go to the last graph. Last two graphs we'll see. Okay, one graph is this, which all of you know, obstruction. All of you are already aware. I think most of you know these answers. You never get mistaken with this one. Shark fin appearance, which is seen in obstruction, or bronchial asthma, which means it is coming slowly, getting obstructed. And the cardiac oscillation means during inspiration, someone having a thin chest wall, these cardiac oscillations are seen. So these are some cardiac oscillations are seen because of a thin chest wall. This is seen especially in a pediatric patient. Okay, so thin chest wall. This is what is called as cardiac oscillations seen during inspiration. That finishes off capnography. Dr. Veer says bronchospasm. Correct, that is bronchospasm. Next one. Which of the following is measured by the device shown in the given image? Amount of inspired oxygen, oxygen content, partial pressure, or oxygen saturation. Simple question, so I'm not even waiting for the answers. I know you people know the answer. It is written here only, and every child also knows. It is written in front of the image also. What is it showing? Showing SpO2, which is your oxygen saturation. Had they mentioned about pulse rate or heart rate, even that is seen, right? Is it showing you inspired oxygen? No. Is it oxygen content? No. Is it partial pressure? No. Right? What it is showing you, the oxygen saturation. Okay, simple. Now the point is, when you're talking about pulse oximeter, what is the information that you get? So you get to know the SpO2, and remember SpO2 should always be more than 95%. Apart from that, you come to know the pulse rate of the patient, and you also get to know the peripheral perfusion, because the whole concept is that this is based on the Beer-Lambert's law. The pulse oximeter is based on the Beer-Lambert's law, that the light is passing through the blood vessel. In the blood vessel, you are getting oxygenated hemoglobin in the artery. You get deoxygenated hemoglobin in the in the vein, and when the light passes on through it, so some light will be absorbed by this, some light will be absorbed by that, and then both are, there's some detector kept over here. So they will see how much light is absorbed by oxygenated, how much is absorbed by this. They calculate a difference, and based on that they tell you how much is the SpO2 of the patient. SpO2 means amount of oxygen carried by the blood. Okay, or the amount of oxygen present in the blood, which is called oxygen saturation. Okay, oxygen saturation. Okay, so this is the amount of oxygen carried in the blood. Now the point is, some people say, sir, what about bilirubin? Someone gets jaundice, will you get a wrong reading? Remember, in bilirubin, if the color is too much yellow, you can get a wrong reading. You get a wrong reading if the hemoglobin has been damaged. In case of jaundice, the hemoglobin has got destructed, but not that the hemoglobin is damaged. What is the meaning of hemoglobin getting damaged? Instead of oxygenated hemoglobin, if you start getting methemoglobinemia, if this hemoglobin is only changed, it becomes dysfunctional hemoglobin. For example, now you get a patient who's got methemoglobinemia. You have got carboxyhemoglobin. Your hemoglobin is only changed. So this shows you a wrong reading, and these are what are called as the limitations of the pulse oximeter. So methemoglobinemia, wrong reading. Carboxyhemoglobin, wrong reading. These are called as dysfunctional hemoglobin. Anything, now this was all based on the blood supply of the blood vessel. Now imagine someone's blood supply has got disturbed. Someone's blood vessel has got disturbed. Less blood supply, you get a wrong reading. Less blood supply means someone must having the shock, someone must be having hypotension, hypovolemia, or anything that causes vasoconstriction, you get a wrong reading. And the third thing is that, correct, wrong value, nail paint, very nice, all of you remember it. Imagine the light is passing through the finger and someone has put something in between, nail paint, dyes, varnish, dark skin, all that. So these become the non-pathological causes like nail polish or nail paint, if there are various dyes, if there is various things like varnish, dark skin, right, lot of light in the room which is called as ambient light. All these are the reasons for the wrong reading of a pulse oximeter. And where do you use it? You can use it on the finger, you can use it on the toes, okay, ear, nose, and in children especially, the wrist and the sole can be used. So those are the places for pulse oximeter. Next one, identify. This question was asked in 2019, 2020, but after that, last 3-4 years, they have not asked you this question directly, whether FMGE, INI-CET, or even NEET PG. Okay, but before that, 2018, 19, 20, like 2-3 years, they asked this question continuously. Anyone? What's the answer? What is being shown? Image based. अरे बोलो बोलो, ये तो इम्पोर्टेंट था, सब लोग डिस्कस करते ही हैं. कोई भी प्लेटफॉर्म पे जाओगे सब जगह एवरीवन इज देयर, एनी प्लेटफॉर्म. डॉक्टर वीर सेज ईईजी, करेक्ट, बेस्ड ऑन ईईजी. पर बोलते क्या है इसको? यस, आई हैव नॉट गिवन यू द ऑप्शन. I know I have not given you the option. You are right, it is EEG. But what is based on EEG? This is what is called as the depth of anesthesia monitor. Depth of anesthesia monitor. It is based on EEG. What you see in front of you is called as a bispectral index. Remember, this is an important question. Important क्यों है? मतलब 2-3 साल से नहीं पूछा हुआ क्वेश्चन है, लेकिन it is important यार. It tells you how deep is a patient under anesthesia. So this gives you a reading between 100 to 0. 100 का मतलब होता है पेशेंट इज अवेक, 0 का मतलब होता है फ्लैट लाइन ईईजी और बेसिकली कोमा, राइट. सो देयरफॉर करेक्ट, डॉक्टर लेजेंडरी ऋत्विक. ओह, आई लाइक द नेम, लेजेंडरी ऋत्विक. तुम लोग नाम भी अजीब अजीब रखते हो ना. मैं तो हर व्हेनेवर आई एम ऑन यूट्यूब ना, आई गेट टू सी सच नेम्स, सो आई ऑलवेज कमेंट गुड नेम्स. गुड नेम्स मतलब डिफरेंट नेम्स. इट शोज योर क्रिएटिविटी, हाउ क्रिएटिव यू पीपल आर. लेजेंडरी ऋत्विक. So next time I'll keep a name. You know the Anaesthesia by legendary Dr. Vinish. Nice, yeah. Good. You have given me an option to think about it. Legendary Dr. Vinish. Anyways, coming back to bispectral index. मेरे को नाम अच्छा लगा legendary ऋत्विक का. That's why I just said that. Okay, don't feel bad, Dr. ऋत्विक. Okay, so 100 is the patient being awake. 0 मतलब flat line या coma. Now a value of 40 to 60 is set for general anesthesia and 60 to 80 is set for sedation. So basically what happens is when you give anesthesia, you want to have a patient value between 40 to 60, which means it is good GA. In GA, if you get a value 100 means patient becomes awake. So this helps you to maintain the optimal depth of anesthesia, and therefore overdose and underdose both get prevented. It is based on EEG, electroencephalogram, right? This is called as bispectral index. एक और मॉनिटर है जिसको एंट्रोपी बोलते हैं, and that is EEG plus EMG. And compared to bispectral index, this is a better one, which we go normally for NEET PG. But एक एक्स्ट्रा पॉइंट तुमको भी पता चल जाएगा तो क्या जाता है यार, even if you are not preparing for NEET PG, this is FMGE, right? So remember, entropy is a better monitor than bispectral index. It contains EEG plus EMG both. Okay, that is entropy. Going forward, next one. This was asked in the exam. This was asked in FMGE only, and this was last year, no, or before that. So the image given below shows the neuromuscular monitoring of the patient after anesthesia. Okay, which is the most common used nerve for this monitoring? Okay, so simple question. You can see it in front of you. Anesthesia questions are normally easy. This time also INI-CET, I mean almost whatever everyone teaches, 100% everyone had a strike rate in anesthesia, because everything came from there. Normally anesthesia, they will not going to ask you difficult questions. They are simple questions which come, right? Correct. So correct answer is C. All of you have said it correctly. ulnar nerve. Remember, ulnar is the most common nerve used for neuromuscular monitoring, and the corresponding muscle would become correctly pointed out. Correct. Adductor pollicis, Dr. Ritvik. Okay. Adductor pollicis becomes the most commonly used muscle. But a lot of people say that ideal is a facial nerve and correspondingly the orbicularis oculi muscle. What you do is you give 4 stimulus, right? Each stimulus is of 2 hertz. It's given in a span of 2 seconds. If there is no paralysis, you get the same response, which is normal. ठीक है, 4 stimulus इधर दिया, you give 1, 2, 3 and 4. You give 4 stimuli here, right? मेरा पेन चला गया, right? 1, 2, 3, 4. You give it over here and you get to see the 4 response on this side, right? If there is no block, you get a normal response. If it is a block with non-depolarizing, you get to see 1, 2, 3 and 4. This is what is called as fade, right? In case of succinylcholine, you get to see 1, 2, 3, 4. Small height. The point is, this is seen in succinylcholine phase 1 block. Remember, succinylcholine has 2 blocks, phase 1 and phase 2. Remember, succinylcholine in phase 2 resembles non-depolarizing. So fade is seen with non-depolarizing and succinylcholine phase 2. That's an important point. This much is sufficient to know. You don't need to know more than this. Sufficient. So that this is what is called as train of 4 mode. Okay? This is what is called as train of 4 mode. This is the most common used mode where you give 4 stimuli each of 2 hertz in a span of 2 seconds. 2 second मतलब हर stimuli के बीच में 0.5 second का gap होता है. And then the normal response would be to get the same 4 responses on the thumb, right? In case of non-depolarizing and succinylcholine phase 2, you get to see fade. In case of succinylcholine phase 1, you get to see same height but decreased amplitude. Same height and decreased amplitude. Okay? So that is about the neuromuscular monitor. Next question. Adjoining image is an image of green cannula. What is the number of the gauge? Okay, is it 20 gauge? Is it 18 gauge? Is it 14 gauge? Is it 22 gauge? Right? So anyone? Okay. Simple है. Again simple question यार. 18 है, 20 है, 14 है, 22 है. Green मतलब it is comparatively thick, right? Thick. So the correct answer here is 18. And it's not my mnemonic, but correct, Dr. Legendary Ritvik. It's a very good mnemonic made by some student only, not by me. But it is a very famous mnemonic which you can use for the cannula colors, right? That is, O great God, right? Please bless your pupils. Okay, this gives you all the colors from 14 to 26. So if you are going to remember this, if you remember this, you know all the colors, each of them, right? So you will see that the 14 is what is the orange, right? 16 is what is gray, green. 18 is what is green color. The 20 gauge is what is pink, 22 is blue, 24 is yellow, correct? And you will find that the purple one, okay, purple one is what is 26. So you have a purple colored one, so that is 26, which is purple in color. So I'm writing it over here. I know it is getting hidden, so I'm writing it over here. 26 is purple. Remember, 14 to 16, these are thick ones, and once after this they become thin ones. So like blue one is used in pediatric patient and is used in, most common used in adults is the pink one, right? Adults who are slightly obese, where you don't get the IV cannula, or pediatric patients, you can use the blue one. Yellow one is used in pediatric and used in neonates, while the 26 purple is used in neonates or can be used in preterm. So these are the thin ones, right? So 22, 24, 26, these are thin ones, and this 14, 16, 18 are thick ones. This is used for blood and fluid resuscitation. Okay? And the flow rates, remember 20 is around 50 or 54, right? बच्चों में उसका half कर दो, around 20 is seen with the 24 gauge, in between is 33, and then you just increase it, double it, you know, so around 80, 180 and 280, you can remember like that. That is green, gray and orange. That becomes the flow rate ml per minute. Now, in case of emergency, now this was a question asked in the NEET PG, okay, and this question was identify the following image. Now, when this question comes as a part of 4 options given from ortho, it looks like an ortho question, guys, but this is not an ortho question. This has been asked as a in general. It's a part of CPR, right? What is this? you have to identify this is what is called as a intraosseous cannula. This was asked last year in NEET PG. Okay, intraosseous cannula. Okay, NEET PG का question था intraosseous cannula. So most common places, this is used in emergency when you don't get an IV access. For example, burns patient or pediatric patient coming for emergency when you can't take an IV cannula. So in these cases, we prefer to use the intraosseous cannula, and this has been asked in the exam. What are the places? The most common used is the tibia. You can also use the femur, anterior superior iliac spine. There can be sternum, right? And a lot of people have mentioned even humerus. So it is inserted inside the bone, and it gives you an access from where the medicines can be given in case of emergency. For fluid resuscitation and medicines can be given into the intraosseous line. So this what you see in front of you is a intraosseous cannula. Okay, intraosseous, right? And humerus is what I wanted to write. So these are the places where you can put the intraosseous cannula in case of emergency. Going forward, specific complications seen with the following procedure. Yes guys, again important question. This was a INI-CET question. Okay, same image based question. Now what is the procedure that you can see? So you can see that someone is inserting a cannula over here into the subclavian. So if you are putting a cannula into the subclavian, it means it is a subclavian central line, right? It's a vein, na? It's not an artery. It's shown in blue color. So it's a subclavian vein, and you are going to put a central line or a central venous catheter. Now, remember whenever we study, right from our first prof, we remember it as vein, artery, nerve. So whenever you are there near the vein, the immediate puncture can be the artery. So no doubt option A is correct. But what they have asked you is what is a specific complication seen with this procedure. Now remember, this is a left-sided subclavian vein, not a right-sided. And here is going to be the apex of the lung. Also, what is going here is a thoracic duct. So therefore, if you are puncturing the subclavian, you are putting a left-sided subclavian. A specific complication that can take place only on the left side, does not take place on the right side, is chylothorax. Okay. If they had asked you what was the most common complication with the following procedure, guys, then the correct answer becomes arterial puncture. Why? Vein, artery, nerve. If someone asks you what is the most common complication seen with the central line insertion, vein, artery, nerve, the next to the vein is artery, straight away arterial puncture. So if the name changes, you have to read what question has been asked. If they say what is the most common complication, the correct answer becomes arterial puncture. But if this is not the question asked, they ask you what is a specific complication, then the answer becomes chylothorax. Correctly said by Dr. Ritvik. Okay? So that is a left-sided central line. When you insert central line, remember you can insert it internal jugular, which is the most common. There is a subclavian, we can use that. You can use femoral. Also, you can use the basilic and the cephalic in the hand, which is used normally with the cancer patients. Okay, basilic and cephalic. So these are the places to insert central line, and remember it is inserted in a vein. Many times they will give you an option subclavian. You will look at my questions also when I have set up, whether on the YouTube or other types in the format also. You will see my questions. I have given the option as subclavian artery, and trust me, when you're sitting in the exam, I have given 3 options of the vein. For example, internal jugular vein. I have given another one as basilic vein, cephalic vein, and subclavian artery. Invariably, what happens is, as soon as I've written subclavian artery, people think only subclavian vein, IJV, both of them people know. Then option becomes कि basilic या cephalic. So इसमें से कोई आंसर मार्क करते हैं जो गलत है, because यहाँ पे I've mentioned artery. Read that, huh? So therefore, read your question before you mark the answers. Just because it is subclavian or internal jugular, read that it is a vein, right? And the tip of the central line lies over here. Tip of the central line lies at the junction of superior vena cava and the right atrium. Remember, this becomes your access to the venous circulation. It is a direct access to venous circulation, right? So when you speak of a central line, it is a direct access to the venous circulation, from where you can know a lot of things, right? So you can know from the direct venous access, you can know the CVP, central venous pressure. कितना होता है? 8 to 10 centimeter of water, CVP. This tells you the fluid status. Based on that, you can start the vasoactive drugs from there. You can give various medicines. You can give total parenteral nutrition. You can give chemotherapy from there. You can do a pacemaking from there, transvenous pacemaker. right? Transvenous pacemaker can be inserted. So vasoactive drugs, total parenteral nutrition, chemotherapy, pacemaker, dialysis. Apart from these things, blood collection and all which can be done, it is used in all the major surgery, right? It is put in ICU, critically ill patient, right? Wherever there is a major fluid shift taking place. So these are the points. Adenosine can be given in PSVT, says Dr. Ritwik. Correct, that's what. Vasoactive drugs means anything which is working on the cardiac patient straight away. So whether it is ADR, adrenaline, noradrenaline, dopamine, dobutamine, all the cardiac drugs, right? All the medicines can be given from there. This is the central line, okay? And the most common complications that you see with the central line, the commonest complication, guys, remember, arterial puncture, because next to the vein is the artery. So the arterial puncture is the most common complication, right? Then the tip is going to the junction of superior vena cava and right atrium. So you can cause cardiac damage also. It is touching the heart. It can cause arrhythmias. In fact, many times when we were trying to learn blind procedures, right? So our seniors used to tell us that if you get an arrhythmia, means you have placed your central line correctly, right? Nowadays we are doing it with ultrasound guidance, but otherwise when we were doing it blind means you're seeing. Blind doesn't mean you're putting something on your eyes and then you do blind. Blind means you cannot see anything, and when you're inserting, so this was one of the signs to confirm arrhythmias. So arrhythmias are seen with central line insertion. And remember, especially pneumothorax can take place on both the sides, but chylothorax is something that takes place specifically on the left hand side, which is important, right? Some books have also mentioned that embolism can take place since it is open to air, right? And infections and bleeding is a separate thing. We're not discussing. It can happen in any procedure. Next question. Okay. Now, this was asked again in INI-CET. And the problem was they had asked you identify. Options given were Roux test, Durkin test, right? Addson test and Allen test. The point is, when you read it, Roux test, Durkin test, Addson test are orthopedic tests, carpal tunnel syndrome and all those things, right? That is where someone gets confused. Arey diya kya hai? Because that is also almost done like this only. So Roux test, Durkin test and Addson test. These are orthopedic tests which are done. But what was asked in the exam, what is being done over here is the Allen's test, right? Allen's test, very nice. This Allen test for the patency of the collateral supply between the radial and the ulnar. It should get filled up in less than 7 seconds. Anesthesia में क्यों important है? To insert the arterial line. Arterial line is your direct access to the artery. This tells you the invasive blood pressure measurement. हम लोग बोलते हैं ना NIBP when you put a cuff. So this tells you the invasive blood pressure measurement, which means it tells you the beat to beat blood pressure. Every beat, you know the blood pressure of the patient. This is important in critically ill patients, ICU patients, right? You know those in major surgeries that are taking place. Also, it's an artery. You cannot put any drug from here. All you can do is withdraw the blood for ABG. These are the only two uses of the arterial line. It is just to check the blood pressure, beat to beat blood pressure in a critically ill patient, right? In major surgery, and it is for arterial blood gas. Dr. Legendary Ithwik says for placing fistula. हाँ मतलब वो भी that is yours doing Allen's test ना, correct. But I am speaking about the arterial line, right? And what is the use of arterial line in anesthesia? So why are we using an arterial line? So in NIBP would take about 5 minutes. Arterial line would just be immediate, immediate. NIBP not 5 minutes, but maybe 2 to 3 minutes. So in those critically ill patients, arterial line becomes very important, right? And arterial line can be inserted ulnar or the radial. The most common is the radial. So radial, ulnar, brachial, femoral and dorsalis pedis. So these are the 5 places where you will insert it, right? Next question. Identify the mask in the following image. Now these are common questions. Last 3-4 years, one question is definitely coming. I'm not saying it's going to come again, but you should be aware for that. You should be aware, right? So these, when you're discussing previous years topics and questions, this becomes a very important one. So identify the mask in the following image. Is it a Venturi mask? Is it a Hudson mask? Is it a nebulizer or a non-rebreathing mask? Correct, Dr. Bhargavi, right? NRBM. This is what is called as NRBM. How did you identify? It as a normal face mask. At the end, you get a reservoir bag. Now, as I told you, last 2-3 years they've been asking questions, so I'm going to cover all 3 of them, and let's discuss this fast then. What is this then? Again, this was asked. This was FMGE last year. This is last year FMGE question. Identify the device shown below. Similar question, similar image, right? Is it a high flow nasal cannula? Is it a Venturi mask? Is it a nebulizer or an anesthesia face mask? Simple. What you see is something that gets attached to the normal face mask, and this is called as the Venturi mask. Very nice. Correct answer, Dr. Ritvik. Okay. So this is the Venturi mask. Venturi mask, right? This is what is called as a Venturi mask. So Venturi mask, guys, remember, is based on the Venturi principle. Right, Venturi principle. This itself is based on the Bernoulli's law of physics. So what happens is that based on the Bernoulli's law, it causes air entrainment. At this time before the exam, let's not think about what is air entrainment. Forget about what is air entrainment, but this one word is important. वो क्या करता है? Because of the hole अंदर air खींच लेता है. बस इतना याद रखो. Because of the hole present here, this is your Venturi mask. Because of this reason, what happens is that it becomes a fixed output device. The important word is it becomes a fixed output device. Fixed output means you know how much output it is going to give. If I'm going to use a red one, it is going to give 40% to the patient oxygen. If I'm going to use a blue one, it is going to give 24% oxygen. Room air is 21%, right? Room air. So if someone is not breathing well, and I want to know exactly, for example, in a COPD patient, if you give 100% oxygen, you people know 100% you give to COPD patient, he'll go up. So you have to titrate the oxygen. You have to know how much exactly it is going, and this is where Venturi devices come for a COPD patient, pulmonary fibrosis, where you have to give titrated oxygen, you have to measure, you have to know how much it is going. This is where we use it. So the maximum still given is 60% only. But do you see 60% is going at 15 liters per minute? This is high flow devices. Do you see that? 40% is going at 10 liters per minute. So when we classify these oxygen delivery devices, so if someone will say what is the classification of the oxygen delivery devices by which you are giving oxygen to the patient, so we classify them as low flow, and the other one is going to be the high flow. So the low flow is going to be your nasal prongs or nasal cannula. Then you have the simple face mask, which is also called as the Hudson face mask. Now to the Hudson face mask, if you attach the reservoir, that becomes a partial rebreathing mask, not a full rebreathing mask. It's called a partial rebreathing mask. And to that, if you attach a valve, means a reservoir and then a valve also on the mask, that becomes a non-rebreathing mask. What is the difference? Nasal cannula works between 1 to 6 liters. Maximum FiO2 is 44%. There's a formula for that. For a nasal prongs, when you talk of nasal cannula or nasal prongs, there's a formula, and a question based on this had come in the INI-CET. Remember, the formula is 20 plus 4 into the flow rate. How much oxygen is going to the patient? So 20 plus 4 into 1, 24. So therefore 1 liter will give 24%. Nasal prongs, 20 plus 4 into 2, 28%. So 2 liter will give you 28%. This is only for nasal prongs. 20 plus 4 into 3, it's going to give you 32%. 20 plus 4 into 4, it gives 36%, which means if you start at 1 liter per minute, it is 24, 2 liters per minute, 28, 3 liters per minute oxygen, 32, and if you give 4 liters per minute, you are giving 36%. Okay, so this is the formula to calculate that. A question based on this was last year's INI-CET question, November question. Okay, so nasal prongs gives maximum FiO2 of 44, which is less. So simple face mask is normally used 5 to 10 liters, it gives around 60%. Now someone is not improving with that, you give a partial rebreathing mask which has a reservoir bag, 10 to 12 liters, it works between that, 70% maximum. Non-rebreathing works between 20 to 15 liters and it gives 90%. Out of all the low flow devices, remember non-rebreathing gives the maximum FiO2, right? These are called low flow. On the other hand, we get high flow devices, right? One of them is the Venturi. The Venturi mask at 15 liters high flow, it provides only 60%, that is the maximum FiO2. The only point is that it is a fixed output device by which you know that how much you're going to give to the patient, right? So this is your Venturi mask, all right? Next question, identify the equipment used below. What is the equipment? Fast, I wanted this answer. Anyone? Is it a nasal cannula? Is it a non-invasive ventilation? Is it a high flow? Very nice. Dr. Bhargavi, very nice. The point is, that is the point. This is a very different thing. Hence, I did not discuss it before. This is not CPAP, guys. This is not non-invasive. Remember, CPAP and non-invasive are the same thing. Okay? Non-invasive and CPAP is going to be the same thing. This looks like a nasal cannula. It is put on the nose of the patient, correct? This is a high flow nasal cannula. How did I identify that? I identified it by the presence of this humidifier. And can you see there's a different type of oxygen supply. This needs 60 liters of oxygen. It needs 60 liters of oxygen to give 100% oxygen to the patient. 60 liters, not 15 liters. 60 liters, and there is a humidifier, and by the presence of this humidifier is how do you identify, right? And now going back to the same question that we were discussing, when we are discussing high flow devices, guys, the next device is what is called as the high flow nasal cannula. And this high flow nasal cannula at 60 liters provides 100% oxygen, and that is why in COVID people started using face mask, not working. We went to NRBM, not working, and then we went to high flow nasal cannula. And do you remember in COVID there was a shortage of oxygen? Why? Because every patient was getting non-rebreathing mask, which is working at 15 liters per minute, and you're getting high flow nasal cannula 60 liters per minute. So many people, pandemic all over India, suddenly the oxygen requirement increased so much, because of which was an oxygen shortage, right? So that's the reason behind it. Now, that's not asked in the exam. That is just a common sense which I try to discuss. Okay, that's one of the reasons that the high flow nasal cannula and non-rebreathing masks were used so much during the COVID that the oxygen requirement went very high. Okay, so these two are the part of high flow, right? Remember, high flow nasal cannula can give 100%. Venturi mask, though it is a high flow device, remember it gives maximum only 60%, which is a point to remember, right? NRBM is more than the Venturi mask, and that is how it is. Okay, so remember this point. Then again, talking about last year's FMGE question, when you speak of ventilation, a question had come regarding ventilation. So remember, when you speak of ventilation, guys, the ventilation can be of two types, non-invasive and invasive, right? Non-invasive का मतलब होता है you can just put through the face mask, and this is where you can use CPAP, continuous positive airway pressure, and BiPAP, bi-level positive airway pressure. This was the January question of FMGE. When you put a BiPAP, which is a contraindication, if anyone has gone through the paper, you'll be knowing that. So remember, in a non-invasive ventilation, you're using a face mask. So if you use a face mask, it means the patient has to breathing spontaneously. मतलब उसको खुद से सांस लेना पड़ेगा. So the point is, during CPAP and BiPAP, because the face mask is used, remember, the patient has to be breathing spontaneously. Only then you can use a BiPAP, only then you can use a CPAP. And the question asked in the exam was, the patient was intubated or unconscious. So in unconscious patient, you cannot use BiPAP or CPAP, because how will you put just a face mask? Here the patient has to be breathing spontaneously. So a sedated patient, unconscious patient, you can't, or some patient not breathing, you can't use CPAP or BiPAP. It has to be used for a spontaneously breathing patient. On the other hand, the next is an invasive ventilation. Invasive means you're going to put an endotracheal tube, or you're going to put a tracheostomy in the patient. Now, here then there can be two things. Two things means either the patient is breathing spontaneously, or if he is not breathing spontaneously, you paralyze the patient and you control the breath of the patient, right? And that is what is called as controlled ventilation, where you get volume control, pressure control. I'm not going to go into details of that. The point is, when a patient improves from controlled ventilation, you can't put him on the face mask directly. You have to have a weaning mode, na? You know that बच्चों को wean किया जाता है from breast milk. Similarly, in ICU also you need to wean the patient. So from the controlled ventilation, you come back slightly with a support ventilation, and this is called as the support mode or the weaning mode, right? So there are two types. So remember, in a weaning mode, patient might be breathing spontaneously though intubated, right? But in a control mode, you have either paralyzed the patient or the patient is not breathing. So these are the two types of invasive ventilation: support ventilation and control ventilation, and we'll not discuss more than this. Thumbs up everyone. Did you understand that in short? Yes or no? कोई आंसर तो दे दो. Yes guys. Anyone? So I'll go forward to the next one. I was waiting for your answers here. Okay, fine. So nothing more is needed over here. Let's go forward. Next one. This is what is called as the high flow nasal cannula that I was discussing with you, right? And high flow nasal cannula, can you see? It's a bigger nasal cannula, and you get this humidifier. This is what is called as the humidifier, right? This provides warm and humidified oxygen to the patient. So this humidifier is what helps you identify the high flow nasal cannula in the exam. Okay, this is what is the nasal prong, right? The first one which we discussed, this is the nasal cannula. Maximum is 44%, simple face mask 60%, non-rebreathing mask maximum is 90%, has a reservoir and a valve. Can you see there's a valve also here? You will see this is the valve. This is the valve which you see, right? Next question. What is the maneuver being performed in the given image? Head extension, jaw thrust, head tilt, chin lift, manual inline stabilization. Yes, this has been asked. गुड इवनिंग डॉक्टर RJ मेडिको. गुड इवनिंग गाइस. तो मैं मैसेज देख ही रहा था तुम्हारा, तब तक ठक से मैसेज आ गया. हेड टिल्ट चिन लिफ्ट, करेक्ट, एब्सोल्युटली करेक्ट. दिस इज हेड टिल्ट चिन लिफ्ट. कोई कलर, दिस इज व्हाट इज हेड टिल्ट चिन लिफ्ट. ओके, हेड एक्सटेंशन नहीं है, जॉ थ्रस्ट नहीं है. तो व्हेन वी आर डिस्कसिंग द CPR, नाउ व्हाट इज दिस? दिस वाज आस्क्ड इन नीट PG. आइडेंटिफाई द इमेज. आइडेंटिफाई. तुम लोग बोलोगे सर कोई सो रहा है, सर सो रहा है, ये सो रहा है, क्या कर रहा है? व्हाट इज दिस कॉल्ड? एनीवन? See, this session is image based questions. I'm trying to discuss all the images from anesthesia, right? That's what I've done. This has been asked in the exam. It's a previous year question, PYQ, NEET PG. Very nice, very nice, very nice, very nice. It's called the recovery position. This point was important to call it as a recovery position. So the point is, when someone collapses, I'm discussing CPR in short. In CPR, the first thing that you see, remember, is a scene safety. That's the first thing. Scene safety means if someone is collapsed on the road, take him to the side. Someone is collapsed on the entrance of the building, take him to the side. Scene safety means safe for the patient, safe for the victim, safe for rescuer, and take standard precautions. Second step is check for response. Once the scene is safe, ask the response. If the patient responds, तो छोड़ दो. नहीं respond करता है, the next step is call for help. Till now you have not checked anything in the patient apart from response. Why did you call for help? So that they can get you the defibrillator, they can get you the laryngoscope, they can get you intubation things, right? So first step is scene safety, second is check for response, and third is help. After the help, after you've called for help, then the fourth step is look for breath and pulse, right? When you are looking for the pulse, you check the carotid pulse, you can check the femoral pulse, and especially in children you can check the brachial pulse. At the same time, when you're checking the pulse, look for the visible chest rise. That's how you will see the breath is there or not. So look at the breath and check for the pulse. Two things to be done simultaneously within 10 seconds. Simultaneous, that's the fourth step. You will get three options. First option is that the patient's pulse is felt and the patient's breath is felt. And when both of them are felt, this is the most common situation seen in the emergency department. You need to keep the patient in the recovery position, which is this, right? That is A. If pulse and breath both are felt, which is the most common thing, there is a casualty medical officer, you're the intern on duty, you find a patient pulse and breath both present, call your seniors and put the patient in recovery position. This is the most common scenario. Someone has a vasovagal, same thing, left lateral, you do it. Vasovagal मतलब मुन्ना by MBBS type. Blood collection देख के someone collapses, right? So in those conditions, keep the patient in the recovery position. Okay, that is to be done. Point number B. Now the pulse is felt and the breath is not felt. So what is missing? Breath. So what do you need to do? Give breaths. What is missing? Give breaths then, right? The breath was not felt in the patient, so give breath. You are supposed to give one breath every 6 seconds. More important, you're going to give 10 breaths per minute, okay? And keep on checking pulse every 2 minutes. That is what to be done. That is the point number B. A was both of the things are felt, keep in recovery position. B was pulse is felt, breath not felt, give the breath. You can give the breath mouth to nose, mouth to mask, and bag mask ventilation. Okay, I'm not writing it down. I think all of you already know it. The third step is C. When the pulse is not felt and the breath is not felt, this is where you start CPR. Now, when you give CPR, there are three things. You are going to give a chest compression, you need to take care of the airway, and then you need to provide the breath. Chest compression is given in such a way, remember it is the lower, अच्छा ये इस बार का INI-CT question है. This was this year's INI-CT question. Lower 1/3 of the sternum, the rate is 100 to 120 per minute, and the depth of chest compression should be 2 to 2.4 inches or 5 to 6 centimeter. And इस बार का जो wrong question था, जो INI-CT में था option, they had given you 3 to 4 centimeter, which was wrong. ठीक है, you can check all the platforms, whatever INI-CT revision we have done, you'll see all of them have the same point. Okay, so they had given the option as 3 to 4 centimeters. Ideally it is 5 to 6 centimeter. So 2 to 2.4 inches, 5 to 6 centimeter, that is the depth. And remember, उसके छाती पे बैठना नहीं है. Let the chest come back यार. Allow the chest recoil. Okay, let the chest come back. This is an important point. Allow the chest recoil. So when you're giving a chest compression, let it come back. When you give a chest compression, let it come back. Do not sit over the chest, just like Manjulika. Today I'm going to save this patient. Alright, so chest compression. Next is airway. Once you have given the chest compression, guys, airway, the point is to remove the obstruction. The obstruction can be a foreign body, the obstruction can be vomitus, it can be the tongue. So therefore, to remove the obstruction so that the airway becomes open or patent, only then your breath will go na. If the airway is not open or patent, if there's an obstruction, if there's a foreign body, how will your breath go inside? Iske muh mein the foreign body hai. How will your breath go inside? The first thing is to remove the obstruction. So you remove the obstruction by removing a foreign body or the vomitus or the secretion, or head tilt chin lift. If there's a tongue is the obstruction normally, right? So you do a head tilt chin lift, right? Head tilt chin lift, and this should not be done in fracture cervical spine where you can do a jaw thrust, right? And then you give breath to the patient. Always give 2 breaths at one time, right? Inspiration over 1 second. Look for the chest rise, and then expiration over 1 second. Remember, important point, no excessive ventilation. No excessive ventilation. So these are the points for your CAB, chest compression, airway, breathing. It is not ABC. You do A, B, C in orthopedics. Why? Because that patient already has a pulse. So that C is out. So this लिए airway, breathing, circulation आता है उसमें, क्योंकि उसमें circulation है. But we are talking of a patient जिसमें breathing भी नहीं है, circulation भी नहीं है. Both are not there. In that case, the answer is not ABC. It is CAB. Okay. Jaw thrust for trauma 2. Yes, jaw thrust is done in trauma 2. That's what I was discussing. In trauma it becomes ABC because normally circulation is there. But when circulation is not there, it becomes CAB. Remember this point. Also, okay, no, that we'll discuss later. यहाँ तक आ गए थे, chest compression वाला हो गया part, right? So you are supposed to start the CPR. Now the next question comes, right? A, B, C, D हो गया. मतलब part 1 was scene safety, next was check for response, third was call for help. You look for the breath and pulse. You had 3 options. Part A, both are present, recovery position. Part B, pulse is present, breath absent, give breaths. Part C, both are absent, start CPR. And this is how you give the CPR. Once you give CPR, guys, remember CPR is supposed to be given 5 cycles of 30:2, right? You give cycles of 30:2. Cycles of 30:2 is given to the patient, and you keep on repeating it for a period of 30 to 40 minutes. And if you get a defibrillator, you will add a defibrillator onto the same cycles which you are doing, right? 5 cycles of 30:2, and this is given for a period of 30 to 40 minutes, right? And when you get a defib, you incorporate the defib in between. Also, when you're giving this 30:2, if 30:2, remember if there are 2 people, you're going to rotate the compressor. And then it comes like this. Add the defib to it. Everywhere it is 30:2 except pediatric patient with 2 rescuers, it becomes 15:2. And in case if you have a neonate, the option is 3:1. Okay, so this is your CPR. Next question, unresponsive patient in ambulance on attachment of monitor shows the following rhythm. What should be done immediately? करेक्ट डॉक्टर ऋत्विक, लेकिन पीडियाट्रिक में अगर 2 रेस्क्यूअर्स हैं तो पीडियाट्रिक 1 रेस्क्यूअर इज 30:2. लेट मी से दैट अगेन, पीडियाट्रिक 2 रेस्क्यूअर्स इज 15:2, बट पीडियाट्रिक इफ यू हैव 1 रेस्क्यूअर इट बिकम्स 30:2. दिस इज इंपॉर्टेंट डॉक्टर ऋत्विक. ओके, good, you guys are well prepared, huh? Don't worry, I think all of you are well prepared. I'm happy. और अभी मैंने बोला हैप्पी, cardioversion. Are how can you give cardioversion? You can't see the R wave. Cardioversion is not the answer. If this is what is the rhythm, you are getting to see a ventricular fibrillation. You will give a cardioversion only if you get to see the R wave. And then only you can coordinate or synchronize with the R wave. But here there is no R wave seen. You just have to give a defibrillation. That is the point. Defibrillate. So chest compressions and defibrillation. Correct, that's the answer. Chest compression and defibrillation. This is what is ventricular fibrillation. So let's come to the next part of CPR. When you started the CPR, okay, correct. So when we started the CPR, remember I told you it is 30:2. You're doing cycles of 30:2, and you also rotate the compressor. And I told you the exceptions where you don't do 30:2. Once you get the defibrillator, attach the defib, check for the rhythm. There are 2 types of rhythm, 4 types. Dying rhythms can be of 4 types. One is pulseless ventricular tachycardia, which is like this. You will get like this, ventricular tachycardia, pulseless ventricular tachycardia. Okay, and then there is ventricular fibrillation, which is like this. The heart is fibrillating, which is what has been seen over here. This is what is called ventricular fibrillation, which you have seen here. Another 2 options that you can get is a pulseless electrical activity and a flat line, which is called asystole. So when you are getting a pulseless ventricular tachycardia or ventricular fibrillation, you are supposed to give a shock. They are shockable rhythms. So you give a shock. After the shock, no pulse check. Immediately resume CPR, 5 cycles, 30:2, which is to be done, and continue the same thing. Rotate the compressor, then check for the rhythm again. In case now you check for the rhythm, right? Now you check for the rhythm. It turns out to be pulseless electrical activity. Will you give a shock? No. No shock is to be given. So for pulseless electrical activity and asystole, all you need to do is straight away start your CPR. Okay? Nothing is to be done. No shock is to be given. This is a non-shockable rhythm. So pulseless electrical activity and asystole are the non-shockable rhythms. Don't give a shock. In case you have adrenaline, you can use it, but normally ADR is not there. Na? In roadside, it's not available. So what are the drugs which can be used? So nowadays the drugs which are, and that is ALS, advanced life support. Advanced life support is different because here you have an airway. Because you have an airway which is endotracheal tube or laryngeal mask airway, you can keep on giving breaths to the patient, 10 to 12 breaths per minute, right? Circulation, remember intravenous, intraosseous access is available now. There is no 30:2, and you can use drugs like adrenaline, you can use amiodarone, lignocaine, and in torcedo do point is magnesium. उसको छोड़ के कोई drug use नहीं होता है. This is all done. You can monitor by diastolic blood pressure waves and by the 𝐸𝑡/CO2, important monitor. In between disability prevention, you keep on thinking what has happened. 5H, 5T, the reversible causes. This is how the ACLS is different from the BLS. This is in short, right? So that is how you do the CPR. Correct, guys? What is the procedure being performed in the image? Yes, simple question है यार. इसमें पूछने की भी जरूरत नहीं. Let me answer. Next one. If there are any doubts, please ask me. मैं थोड़ा fast जा रहा हूँ so that I finish in the next 10 minutes, 10-15 minutes. Okay? So don't want to waste a lot of time of yours. Right? What is the procedure being performed in the image? It has been asked before. This is tracheostomy. Okay? Tracheostomy. Right? So intubation is when a tube is put in the trachea, but it's a oroendotracheal intubation. It goes like this, right? That's an endotracheal tube which we use. That's a tracheostomy. When you put an endotracheal tube, again, these are the images which comes from the when you're doing the intubation of a patient, right? Okay, so this is what is called as a Macintosh laryngoscope or blade? Macintosh. It's a curved blade that is used in adults. Then this is what is called as a Miller blade. This is the straight blade, and straight blade is what is used in pediatric patient or children, right? Then you have McCoy. This is not asked in exam yet. It has not been asked yet, but Miller and Macintosh have been asked. Curved and straight blades. McCoy is a hinge tip blade with a lever, right? This is a hinge tip. There's a hinge joint over here. There's a hinge joint and there's a lever over here. So when you press the lever, the hinge joint goes up, right? There is a hinge joint and a lever. This is used for difficult intubation in anesthesia, right? So this is the three types of blades which are commonly used. Next, when you're doing laryngoscopy, this is the most common position for laryngoscopy, and it is not the rose position. Most of the time I get to hear, sir, rose position. It is not rose. I know you people have all studied ENT so well, and you know ENT very well. It's not called the rose position. Rose is for ENT. Okay. For us, it is sniffing. This is called sniffing position. It can also be called as McGill position, right? So what is happening is there is a extension of the atlanto-occipital joint. What you can see is extension of the atlanto-occipital joint, or the head extension, or there's a flexion of the lower cervical spine. What happens? The three axes come in one line. Oral axis, laryngeal axis, pharyngeal axis. They all come in one line, because of which your laryngoscopic view becomes easy. So this is called as the sniffing or the McGill position. Okay, right? All the three axes come in one line. Oral, laryngeal, pharyngeal. It makes your view of view of the larynx easy, glottis easy, right? This is endotracheal tube. We need to know the parts also. So the one end that gets connected to the machine is called as the connector, which gets connected to the umbu bag. The other end is the patient end, which is called as the bevel. Next question. तो यहाँ पे एक छोटा सा opening है, इसको क्या बोलते हैं? What is this called? I want that answer, because that has been asked in the exam. Yes, guys. Anyone? What is it called? अरे famous name है, Murphy's eye. This is what is called as the Murphy's eye. Remember this यार, exam में important question है Murphy's eye. Okay, Murphy's eye is the additional port for oxygen of the patient, oxygenation. In case your bevel gets obstructed, this provides additional oxygen to the patient, right? It's a safety mechanism basically, Murphy's eye. Okay, the point is if you don't know, then you will be thinking that it's an ophthal question. Where is Murphy's eye? Ophthal. Okay, this is the cuff. The cuff that is used nowadays is a high volume, low pressure cuff. Remember that. Okay, and this decreases the chances. Very good, Dr. Akash. Dr. Akash says Murphy's eye. Correct. Okay, this cuff that you see is a high volume, low pressure cuff, and this decreases the tracheal damage which is seen. Okay, the cuff. And the cuff is what prevents aspiration. This is the reason why aspiration is getting prevented. The whole point of that. And the cuff gets inflated from the air that comes from the inflation line, and this is what is called as the pilot balloon. This is pilot balloon. This is the inflation line. These two will not be asked in the exam. They normally don't ask you this. What they ask you is, what is this? ये क्या line है फिर? What is this line which you see? The next one. So pilot balloon, inflation line, they will not normally ask you. It is not asked. What is this one then? This black line. Again, when I ask many people, ना क्या बोलते पता है? Radio opaque line. This is not the radio opaque line. Radio opaque line is here, which you see, the blue line which you see at the back. This is called as the radio opaque line, which is seen on the X-ray. ठीक है? So that is what is called as the radio opaque line. Yes guys, what is this answer then? इसको बोला जाता है vocal cord marker, or this is the vocal cord guide. It tells you where to put the endotracheal tube. So this vocal cord guide lies at these vocal cords. Okay, that is the meaning of the vocal cord guide. अगर cuff इधर आ गया, this cuff is what prevents the aspiration. You will see the secretions will get accumulated here. This prevents aspiration. This is the bevel, right? Here was the Murphy's eye. So this black line lies here. It tells you Yes, vocal cord marker, then it is supposed to lie at the vocal cord guide. This is supposed to lie at the vocal cords. Okay, so once it lies at the vocal cord, it means you are placed correctly. And then you have these numbers written here, 20, 24, 26. So in a male patient, the number at the teeth is 21 to 23. In a female patient, it is 19 to 21. So these are called centimeter markings. You see this? 18, 20, 22, 24, 26. So in a male, these are called centimeter markings from the tip. Okay, so these markings are called centimeter marking. These centimeter markings in a male patient is 21 to 23. In a female patient is 19 to 21. Right? Another thing you see is ID. What is ID? ID is the internal diameter of the endotracheal tube, and remember, internal diameter is the size of endotracheal tube. Right? Internal diameter is also the size of endotracheal tube. And this, another question, internal diameter is on what the resistance of the endotracheal tube depends. So in case if your tube is long and so much air has to pass through this, right, and I shorten the diameter and I take the same air which has to be passed into it. Now do you realize the resistance increases? So therefore the resistance is inversely proportional to the radius or the diameter. This has been asked in FMGE only. So resistance of endotracheal tube is inversely proportional to the internal diameter, right? And internal diameter tells you the size of the endotracheal tube. Clear? All of you? कोई doubt तो नहीं है? ठीक है? And if you talk about the size, in a male patient, the normal size which is preferred, size of the endotracheal tube is 8 or 8.5. In a female patient, we use 7 or 7.5. Clear? So this is about the endotracheal tube and the images based on that. Remember, the best method to check intubation correctly is capnography, because carbon dioxide will come out from here, and if you keep a monitor over here that can see that can detect carbon dioxide, it means carbon dioxide is coming from here and carbon dioxide is not coming from the esophagus ना. Esophagus से carbon dioxide थोड़ी आएगा, तो खाली burp आ सकता है. Carbon dioxide इतना थोड़ी आने वाला है. You know, a student had told me, sir, burps also come ना, that is also carbon dioxide. तो बात तो सही थी यार, लेकिन because of that your graph is going to be like this. Initially a little bit carbon dioxide has come up, जो burp हुआ, लेकिन उसके बाद तो carbon dioxide is not going to come. So CO2 is going to come only from your trachea, all right, and that is why this becomes the best method. So capnography becomes the best method to detect intubation. And if they have not given capnography or EtCO2, the next answer becomes fiber optic, because fiber optic is something which is a direct visualization. So both of them are considered as best methods. Okay, that is for intubation. Next question. Identify. There are two images that you get and both are different from each other, right? The first image which you see, remember how to identify the difference between them. The first image is where an assistant is giving the pressure. In the second image, जो intubate कर रहा है, the same person is giving the pressure. So the difference is what? When the assistant gives the pressure, this is called as the cricoid pressure, which is called as the Sellick's maneuver. And Sellick's maneuver is what is done in a full stomach patient or where there is a risk of aspiration condition, where you give a 13 Newton pressure. Okay, 13 Newton pressure is given. Okay, that is cricoid pressure, but this is not cricoid pressure. This is called when the same person, he is manipulating. So this patient, what is this person doing? He is doing a manipulation of the larynx. This is called optimal external laryngeal manipulation or the burp maneuver. This is called as to increase the laryngoscopic view before intubation. For example, you suddenly get a difficult intubation, you are unable to intubate. What you're doing is just moving the larynx. For that movement, they made a fancy name. मतलब larynx को हिलाना, trachea को हिलाना by the person who is intubating. That is called as OELM, optimal external laryngeal manipulation or the burp maneuver. And when some assistant is giving, that is called cricoid pressure, which shuts off the esophagus. So in case there is any aspiration coming from here, it will get blocked here. Okay, so this is the difference between the cricoid pressure and the optimal external laryngeal manipulation. Same person and the assistant. That's the point. Clear? Next, types of endotracheal tube. Last year FMGE mein this was given as one of the option. This is what is called as the ring Adair Elvin tube, RAE tube. I think so. In one of the questions, this was given as the option. Okay, it was not a direct question asked, but in somewhere they had mentioned this as an option. So this is called as ring Adair Elvin tube, right? It has got a pre-formed curve. If it faces the foot of the patient, it is called south pole tube, which you can see over here. The other one is called north pole tube. Okay, so this is south pole or the north pole. This is used in maxillofacial or oral surgery, cleft lip, cleft palate, or any oral surgery you do it. Now, if you get a surgery where the patient is prone, if the patient is lying, neurosurgery getting done, or a spine surgery getting done, and suddenly the tube bends, in that case what to do? Nothing can be done because the patient is lying prone, neuro, spine. In that case, we use a tube which has a metal wire inside. It has a spiral metal wire. This is called as a flexometallic tube. Flexometallic tube. It is also called as armored tube. Some people also call it reinforced tube, used for prone position, neurosurgery and spine surgery. Okay, you are operating upon the lungs. One lung is getting operated, the infection can go to the other lung. So for that we use a special tube which is called as a double lumen tube. This is what is called as a double lumen tube. This is used for one lung ventilation, where you isolate the lung and operate upon the other lung, right? Apart from that, there are special tubes that are used in ENT. Especially in ENT, you have laser resistant tubes. And for a vocal cord surgery, you use something called as microlaryngeal tube. Microlaryngeal tube. Okay, in a vocal cord surgery, microlaryngeal tube is used. Then, when we speak of pediatric patients, guys, okay, in pediatric patient, routinely what happens? In a pediatric patient, if the age, right, a pediatric patient, what we will do is, if the patient normally is more than 6 years, okay, so we use cuff tubes. Normally, cuff tubes for more than 6 years of age. If someone is less than 6 years of age, it is uncuffed tubes. Less than 6 years of age. More than 6 years of age, you will use cuff tube, less than 6 years uncuffed. But nowadays what has happened, we use also micro cuff tubes. And micro cuffs can be used between 2 to 6 years, I mean in between. And less than 2 years is always uncuffed. But the ideal difference is between cuffed and uncuffed tubes, right? That is for a pediatric patient. Remember, in a pediatric patient, the narrowest part of the airway is subglottic, below the glottis. Important. Okay? Done. So this much is what is important from the airway point of view. Next, coming to the laryngeal mask airway. This was a question asked in INI-CET also, Abhi. The first one that you see is what is called as a classic LMA. The second one, what you see, is called as a ProSeal LMA, and the third one, what you see, is a iGel. Difference: the first one has one tube, the other two have got two tubes, right? So when you classify a laryngeal mask airway, guys, you classify them basically into having one tube or two tubes. Routinely, most of them are one tube, like classic LMA. If you take intubating LMA, AMBU LMA, okay, flexible LMA, all of them are one tube. There are only 3 devices in 2 tubes. You get ProSeal LMA, you get LMA Supreme, and you get iGel. The point is, these 2 tubes means it has got one airway tube from where ventilation can take place, and it has got a drain tube from where the suctioning of the stomach can take place, and therefore this can be used. The 2 tubes, one can be used for IPPV, and these ones slightly not used for IPPV in anesthesia. You can't. In emergency is a different thing, but ideally cannot be used for IPPV because these have 2 tubes, they have a drain tube, hence they can be used for IPPV in anesthesia. That's the difference between them. So if you look at the ProSeal LMA, the second this is where the Riles tube goes inside. In the iGel, this is where the Riles tube goes inside. An important part is iGel is a cuffless LMA. There is no cuff. So this is also called as a cuffless LMA. Just insert inside and the patient's life is saved. Okay? Clear? So this LMA is very important, guys, remember. And the tip of the LMA, guys, remember, lies at the esophagus. It's a laryngeal mask airway, and the tip, this lies at the esophagus. Okay, the tip of the LMA. Clear? Next, this is what is called as the oropharyngeal airway. Okay, it is also called as mouthpiece or girdle airway, oropharyngeal, right? And this is used to prevent the backfall of tongue. So you know how to identify it now. The size is from the mouth to the angle of mandible. The size is mouth to the angle of mandible. It comes in different sizes. Contraindication: never use it in awake patient because you will stimulate the gag reflex. In awake patient, you get a gag reflex, laryngospasm, vomiting, and aspiration can take place. That is why in an awake patient, the next device becomes useful, which is called as a nasopharyngeal airway. This is what is NPA, and the size is from the tip of the nose to the tragus. Okay? This also does the same thing. It prevents the backfall of tongue. But advantage, you can use it in awake patient. Okay? This is what is called as bag mask ventilation. Contraindications: where not to use, all the risk of aspiration condition, जिसके ऊपर question last year भी पूछा गया था INI-CT में. Risk of aspiration conditions are what? Patients who are full stomach. Full stomach means something apart from that: pregnancy, obesity, ascites, tumor, ये सब हो गया. Intestinal obstruction, volvulus, hiatus hernia, GERD, okay, gastroesophageal reflux disease, patient who are on opioids. This is basically delayed gastric emptying, diabetes mellitus, and congenital diaphragmatic hernia, tracheoesophageal fistula, meconium aspiration syndrome. These are all congenital causes, and pyloric stenosis. Here bag mask ventilation should not be done, and congenital diaphragmatic hernia was the question asked last year INI-CT. Okay, so these are all the congenital causes, right? Remember, bag mask ventilation side effect: it increases dead space. Tracheostomy and endotracheal tube decrease the dead space. Okay, done. So we are done with the bag mask ventilation also. The last question: postero-anterior view of chest X-ray is given here. What is the diagnosis? Yes, guys. Postero-anterior view of the chest X-ray is given. What is the diagnosis? So is it right pneumothorax with a right tracheal shift? Is it right pneumothorax with a left tracheal shift? A left pneumothorax with a left tracheal shift, or left pneumothorax with a right tracheal shift? Anyone? C. नहीं यार, C कैसे होगा? You look ना, यहाँ पे black दिख रहा है. ब्लैक का मतलब है कि न्यूमोथोरैक्स यहाँ पे है. इफ दिस इज द न्यूमोथोरैक्स, ठीक है, करेक्ट. तो राइट साइड ना, तो राइट साइड पे न्यूमोथोरैक्स हो गया. ट्रेकिया कहाँ है? कैन यू सी द ट्रेकिया इज गॉट हियर. अगर न्यूमोथोरैक्स है, दैट एयर इज पुशिंग द ट्रेकिया हियर ना, यहाँ पे हवा भर गया है. तो जो हवा भर गया है, व्हाट इज इट डूइंग? इट इज पुशिंग द ट्रेकिया ऑन टू द अदर साइड. सो व्हाट इज हैपनिंग? योर न्यूमोथोरैक्स इज ऑन द राइट साइड एंड ट्रेकिया इज गोइंग टुवर्ड्स व्हिच साइड? लेफ्ट साइड. तो व्हाट इज द आंसर? राइट न्यूमोथोरैक्स विद अ लेफ्ट ट्रेकियल शिफ्ट. अरे राइट शिफ्ट नहीं है ना, उस तरफ नहीं खींच रहा है. लुक एट दिस ना, सी इट इज नॉट पुलिंग इट हियर. द pneumothorax is pushing it there. Look at this, it is trying to push it there. There is a pneumothorax in the air, it's trying to push it there. So therefore what is happening is the right pneumothorax and it is trying to shift here. That is according to me. So right pneumothorax and the shift of the trachea is onto the left side. ओके, ये डाउट है. तो डाउट है तो फिर राइट भी हो सकता है. राइट न्यूमोथोरैक्स विद राइट ट्रेकियल शिफ्ट. ओके, अकॉर्डिंग टू मी इट शुड बी द लेफ्ट साइड. ओके, अपार्ट फ्रॉम दैट एनी क्वेश्चन, एनी डाउट? सो डॉक्टर स्टडी 5 says B. Correct, that's what I am going with. ठीक है. Alright, so that finishes off. Any questions, guys? So all of this will be uploaded on the PW Medit Telegram channel. Any question that you want me to discuss, please let me know, right? And my Telegram ID is Dr. Vinish, DRVINISH. You can ask me questions directly on that also. It's a part of a channel itself. So my PDF will be uploaded there by tonight. and that's my Telegram ID where you can ask me questions directly. Okay? You can ask me on the group as well, but Telegram ID, that's my ID. Any questions and doubts, guys, please ask me. We'll try to solve them to the best of my knowledge, whatever I know. Okay? According to me, I try to cover most of the topics from anesthesia in terms of the image-based questions and previous year's topics. We try to finish off everything from there. Yes? So thank you everyone for joining me in the session. And any questions and doubts, please let me know. Thank you, guys. Thank you. No doubts? Okay. All the best. Do well. And if there's anything, do let us know. Okay. Always there to help you guys out. All the best. Please, all of you have to clear. Believe in Almighty. Pray to God. Right? And have your parents' blessings. Okay? Okay, so there's one question that Dr. Ritvik is asking, sir, neuroleptic malignant syndrome versus malignant hyperthermia. Good question, very nice. I'll solve it out. Okay, so one question Dr. Ritvik has asked. Now, the point is neuroleptic malignant syndrome. So remember, neuroleptic malignant syndrome. Khali naam padho yaar. Sometimes na just go into the basic. Neuroleptic malignant syndrome. What does neurolept means? It means antipsychotic. Okay. So basically malignant syndrome because of the antipsychotic drug. You have given some antipsychotic drug because of which the patient, something has been done in psychiatry because of which the patient's temperature is increased, and this is called as neuroleptic malignant syndrome because of the antipsychotic drug. On the other hand, malignant hyperthermia takes place in anesthesia. This is a genetic disorder. Okay, so malignant hyperthermia is a genetic disorder of sarcoplasmic reticulum having the ryanodine receptor gene abnormality. So there is something called as a ryanodine receptor, right? And ryanodine receptor is what is a calcium release channel. So it is a disorder of the calcium release channel. So when someone is exposed to anesthesia drugs, like someone has got the genetic disorder, and to that patient who's walking and talking normally, I expose the patient to anesthesia drugs, not antipsychotic drugs. Anesthesia drugs like halothane, volatile anesthetic agents, succinylcholine or lignocaine. Suddenly there is bhar ke calcium release that takes place. Because of the increased calcium release, there is going to be arrhythmias in the patient, right? And then there is going to be increased metabolism in the patient. And because this sarcoplasmic reticulum is present in all the muscles, there is muscle rigidity and the muscles get involved, right? So all the problems happen because of this reason. Increased calcium release leading to arrhythmia, increased metabolism leading to increased temperature, and it does not go down, because of which it is called malignant hyperthermia. The treatment of malignant hyperthermia is dantrolene sodium. There's nothing else you can do in the OT. And if a patient like this is coming for surgery, in that case the drug of choice becomes propofol for GA and procaine for local anesthesia drug, because you can't use lignocaine. This is Dr. Ritvik. Okay? Got the answer? Hopefully your point is clear. So neuroleptic malignant syndrome is because of antipsychotic drug, psychiatry, and malignant hyperthermia, the genetic disorder of sarcoplasmic reticulum, ryanodine receptor gene abnormality. Okay? And it is on exposure to anesthesia drugs. Right? Thank you, Dr. Ritvik. It was a good doubt. It's a genuine doubt. Huh? It's a genuine doubt. Very good question. Questions भी तो अच्छे होते हैं. Good question. So all the best, guys. Do well. Okay? And all of you will clear. Be confident about yourself. Pray to Almighty. Seek your parents' blessings, and you will get through. All the best to everyone. Okay? And once you clear, do let us know. We love to hear that. When everyone is clear, we love to hear all the messages that we get. Okay? Chalo, all the best. Do well.